الأستاذة الدكتورة ريم محمود هتتكلم على how to create your neuroprotective neonatal ICU, a simple approach to a complex population.
بسم الله الرحمن الرحيم. I am honored today ان انا ابقى معاكم هنا النهارده وسط اساتذتي اللي I'm heavily in debt ليهم، بحبهم كلهم، بحب القصر العيني قوي قوي. How to create your neuroprotective neonatal ICU, a simple approach to a complex population. Third trimester is a period of intense growth and development of the fetal CNS. The brain size be increased 17 folds in the second half of pregnancy. So if we compare the brain of a 26-weeker compared to a 36-weeker, we can see the difference in size, sulci and gyri. Extreme preterm infants are exposed to the noxious neonatal ICU environment in a period of critical brain development. Advances in the medical care led to increase the survival of preemies and lengthy stays in the neonatal ICU with many life-saving procedures. A preterm baby be removed from the womb suddenly, and he is neurologically not prepared for this. Very preterm infants are at high risk for long-term neurodevelopmental impairments because of their immaturity and medical status. So the mother is having unrestricted access to the baby in utero. The baby is enjoying quiet, warm, dark environment, receiving optimum nutrition. Then suddenly to the neonatal ICU where there is a lot of painful stimuli, disturbed sleep, excessive noise, bright light, and sensory overdrive of frequent handling, probes, wires, and tubes. What is neuroplasticity? Newborn brain is capable of making temporary and permanent changes to the number and strength of his synapses. These adaptations depend on sensory input and experiences he is subjected to in the neonatal ICU. Neuroplasticity be peak early in life علشان there is rapid brain growth. It may be positive or negative. The synapses may be functional or dysfunctional according to his experiences in the neonatal ICU. How to assess a neurological insult impact on the brain of the baby in the neonatal ICU? We may use clinical scores, a Sarnat score and Bind score. We may do lab tests as blood gases and serial ultrasounds to detect hemorrhages and periventricular locomalacia, MRIs, amplitude EEG, and hearing tests. This cranial ultrasound done on first week of life showing cystic periventricular locomalacia, repeated again on 6 days of life showing ventricular dilatation. On day 7, this cranial ultrasound is showing hemorrhage in the left ventricle. 5 weeks later, showing that the resolving ventricle and ventricular dilatation due to hydrocephalus. MRI is very sensitive to detect hypoxia. Amplitude EEG is something very useful and beneficial in the neonatal ICU. It is a simple method of continuous brain function monitoring. It detects abnormal electrical activity. So we may detect convulsions, which is clinically cannot be detected. A near-infrared spectroscopy is a simple bedside non-invasive maneuver modality which can detect, it measures the concentration and oxygenation of hemoglobin in brain muscles, and it's used to monitor critically sick newborns, hypoxic babies, babies with intraventricular hemorrhage, and hemodynamically significant PDAs. Any baby admitted to our neonatal ICU be undergo a hearing test in the form of auditory brainstem responses before his discharge. Early detection of hearing impairments may prevent language and behavioral disorders. Neuroprotection in the neonatal ICU is any modality done in the neonatal ICU to promote normal development and prevent long-term disability, including therapeutic cooling, neuroprotective agents, and neuroprotective family-centered developmental care bundle, which we will concentrate on today. Premature babies and hypoxic babies need most neuroprotection. Therapeutic hypothermia made a revolution and drastic change in the management of perinatal asphyxia in the neonatal ICU. Very simple idea. We just cool the baby, core temperature 33 to 34. Metabolic demands of the baby decreases. And then, so the amount of oxygen available to the cells is sufficient. There is a therapeutic window of 6 hours within birth to prevent a reperfusion injury. We cool to 33, 34 degrees centigrade. Inclusion criteria is near-term or full-term babies, pH of 7 or less, moderate to severe encephalopathy, Apgar score of less than 5 at 10 minutes, or assisted ventilation at 10 minutes because of failure to initiate breathing. This study was published in New England Journal. It concluded that whole body hypothermia reduces death and poor neurodevelopmental outcome at 2 years of life. And since then, therapeutic hypothermia became a standard point of care in our neonatal ICUs. This study published in International Journal of Molecular Sciences listed some of the neuroprotective agents. Most of them is still under research. The most important of them is a stem cell therapy, in which the cord blood of hypoxiated babies is taken, stem cells transfused, the stem cells separated and re-injected in the baby as an adjuvant to the cooling. And very promising results are coming. Neuroprotective bundle is neuroprotective family-centered developmental care implies creating an optimum environment in the neonatal ICU which manages pain and stress and keep the family involved in the care of their preterm babies in the neonatal ICU. Implementation of neuroprotective education and subsequent change of care practices led to marked improvements in the outcome, length of hospital stay, and hospital cost for these babies. The 7 core measures of neuroprotective care include first, a healing environment. Healing environment not only space privacy, but it involves all the sensations and experiences in which the baby is subjected to in the NICU. The development of the sensory system in the fetus have a certain order, starting with touch, then proprioception, olfaction, auditory, ending with gustatory and visual. So the baby is not prepared for any visual stimuli before 37 to 40 weeks after birth. Containment is applying gentle, firm, deep, and stationary touch to the baby, resembling a uterine wall. If the baby push, we push back. This is the optimum way to manage a baby in the neonatal ICU, and swaddling as well. We'll come to swaddling later. The second core measure is partnering with families. We should communicate with the families about the medical and developmental needs of their babies, actively listen to them, educate them, and assist them to become a vital member in the care of their babies 24/7. And the most important issue is early, prolonged, and frequent skin-to-skin care. Although skin-to-skin care in the past was designed only to stable growers, lately they decided and it could be applied also to ventilated babies, and they designed this standing transfer technique to supply skin-to-skin care even to ventilated newborns. This is a simple video demonstrating it. We need the صوت بتاع الفيديو.
Possible to learn how you can do kangaroo care with your baby. If it isn't a good time to do kangaroo care, ask how you can be involved in other types of gentle touch, like hand hugging. Plan your kangaroo care with the healthcare team to make sure you have enough help to pick up your baby. If you are nervous about picking up your baby, ask your baby's nurse if you can practice first. If you are pumping milk, plan to pump before, during, or after kangaroo care. Have a breast pump close by. Hold the wrap over your baby's body while you are standing and in a safe position. You may need help with this step. If you find it easier, the wrap can be pulled up after you sit down. You will figure out what works best for you. The wrap keeps the baby safe and secure and provides containment and warmth. When you hold your baby, familiarize yourself with their regular skin color, body language, and breathing pattern. Let's watch this family. Let's watch this family pick up.
The third core measure in the neuroprotection bundle is therapeutic positioning and handling. It is considered a corner milestone in the care of extreme low birth weight babies. Therapeutic positioning influences the brain, neuromotor, musculoskeletal development, as well as skin integrity, thermal regulation, and bone density. What is the ideal position? Midline position, in which the head and the chin are midline. Flexed contained position, and this may be achieved by using positional aids. We need always try to apply a four-handed support during positioning and caring activities. This may be a limitation in our neonatal ICUs because of shortage of staff. So we can always use the parents to help us applying this four-handed support. Swaddling when bathing and weighing, we will show now how can we swaddle the baby and promote hand to mouth. The hand should be midline close to the mouth for self-soothing, and reposition the baby with care every 4 hours and avoid sudden movements. So by gravity, the baby is always thrown in this bad position, WM position, in which the arms are abducted and external rotated. Try always, the brain perceive this position at the baseline position, and this may lead to neuromuscular deformities. We should always keep him in the good position, flexed, midline, and contained with the hand near the mouth. This is a nice baby, nicely contained. And for the ideal position is not only in a supine, but can also be prone position. We maintain flexion and midline orientation also in prone position using the suitable positional aids.
Position the prone plus from above the umbilicus to the head, no wider than the infant's nipple line. Hold and slowly rotate the infant to a prone midline position. Ensure that the hands are toward the mouth for self-soothing. Be sure the hips are rounded and the feet are placed in the snuggle up. The infant should be supported from the top of the head to the navel. The hips should be flexed. The elbows should be tucked into the indentation on the prone plus to support rounding of the shoulders and hand-to-mouth movement. Adjust the straps to provide containment, while also allowing for dynamic movement at the hips first, then shoulders. Moving slowly, following infant's cues, and round the bendy bumper to rest against the infant's head to comfort and contain. The bendy bumper continues around the back and outside of the snuggle up. Position.
This is a photo of swaddling. These babies are swaddled, and it comes from very long ago in the Egyptian culture that we used to swaddle babies like this. And this swaddling is used even when bathing the babies. There is very nice videos about swaddled bathing. The fourth core measure is safeguarding sleep. And this is considered a very important core measure in the neuroprotective bundle in the neonatal ICU. REM and non-REM sleep cycles are essential for the brain plasticity, neurosensory development, memory, and learning. We should assess the infant's sleep-wake states and clusteral care based on them. Use an incubator covers and protect the eyes from direct lights. Use adjustable lights. Arouse the baby using soft voice or a gentle touch. Promote a quiet environment to ensure uninterrupted sleep at least 60 minutes, because this is the sleep cycle in a preterm baby. And provide some prone to play time for the infants who are back to sleep. The infants who knows that when they are on their back, they are sleeping. Offer them some prone position to play in them. This study was published in Journal of Perinatology. We are striving towards a day-night cycle in the neonatal ICU, and they concluded in the babies offered day-night cycle in the neonatal ICU gained more weight, had more stable respiratory rate, levels of cortisol dropped in them, length of hospital stay shortened with less days on the ventilator. The fifth core measure is try to minimize stress and pain. Stress increases energy expenditure and hence impairs the growth of the baby. Painful interventions increase the cortisol and limit the neuroplasticity. How can we do this? We provide non-pharmacological support. The most important of them is a skin-to-skin care, positioning, sucrose in a pacifier, containment, and swaddling. Breastfeeding and the breast milk, the taste and the smell of the breast milk be decrease the response to pain. Involve the parents in supporting the babies during painful procedures and use pain assessment tools to detect whether you need a pharmacological support as well, like acetaminophen or opioids, and always educate the mothers about the cues of their babies related to pain and stress. Number 6, we have to protect the skin of the baby. And the cornerstone of this core measure is to enhance early, frequent, prolonged skin-to-skin care, not only with the mother, but the father as well. Humidity is very important to extreme low birth weight infants. We should minimize the use of adhesives and remove them cautiously. Avoid using soap and emollients. If you need to bath a baby less than 1 kg, bath him with water only. More than 1 kg, you use neutral bathing agents. Educate the mothers on swaddled bathing. The baby is swaddled as the picture before, and then gently introduced in a tub full of water. And we wash the head first and then each limb separately until we remove the piece of cloth. Finally, but most importantly, optimizing the nutrition of the baby. We should incorporate a cue-based infant-driven feeding practice and educate the mothers about the cues of feeding for the baby. Like he's opening his mouth, he's moving his hands towards the mouth, he is moving his head, stretching, moving hands and legs. Then we allow the mother during gavage feeding. The baby should apply non-nutritive sucking on her pumped breast. We can let him taste some breast milk or smell the smell of his mother. And we may promote side laying position close to the parent if the baby is formula feeding. Most important, skin-to-skin care during gavage feeding. Study published in the archives documented some very simple practices in the neonatal ICU, which may help prevent intraventricular hemorrhage. Giving antenatal steroids, delaying cord clamping, decreasing slower infusions of IV fluids, avoiding fluctuations in the blood pressures, the midline flexed position, head elevation, and finally containment. So these very simple maneuvers, which can be implemented in any neonatal ICU, drastically reduce the incidence of intraventricular hemorrhage. Very wide spectrum of developmental problems for NICU graduates. We should always plan a follow-up after discharge for our NICU graduates. This follow-up is based on the scores using Bailey's scales and Denver scales. According to the score of the baby, we decide about the time and the frequency of his follow-up visits. What we can do as an addition to our neonatal ICU should design training programs that standardize a practice of comprehensive neuroprotective developmental care bundle in our NICUs. For this, we need to train our nurses and involve the parents in 24/7 care of their babies. We may introduce an amplitude EEG and make a hearing test a routine care. And finally, establish a neurodevelopmental clinic in our neonatal ICUs. The neuroprotective bundle should be a standard point of care in our neonatal ICUs, and we try to improve gaps between evidence and practice. We should focus on multidisciplinary NICU staff training and establishing guidelines which is tailored to the circumstances of our NICUs. The neonatal integrative developmental care model, including the 7 neuroprotective core measures for family-centered developmental care, is easy, affordable, and practical, and can be implemented with a
ميرسي قوي دكتور ريم على الفيري نايس برزنتيشن. انا مش عارف الميكروفون شغال ولا لا الحقيقه. احنا كمان محتاجين نيورو بروتكتيف ايجنتس في السن ده، يعني اتس نيدد فور بوث اكستريمز اوف ايج. فيعني المره الجايه بقى قولوا لنا بتوع الجيرياتريكس عشان نستفيد احنا. اتس ا فيري نايس برزنتيشن. Our next speaker اوكي استاذ دكتور محمد عبد المنعم، وهي دينا برزنتيشن على الاكستنسيف جينيتك سيكونسي for early detection of genetic disorders in the NICU, a global perspective.